Jang.
Thank you. Thank you for the opportunity. My name is Kristine Jang. I'm a Cardio-Oncology Fellow at Memorial Sloan Kettering in New York City, and I will be presenting a journal club this morning. So I have selected this paper that was published in JACC Cardio-Onc recently.
Carissima.
Yeah, so I don't know.
Something happened?
Yeah, so it sounds better now. Sorry, I don't know what it was that. What was that?
Just
Okay.
feedback on somebody's microphone. Sorry.
Okay, no problem. I'll be presenting this paper that was recently published, very interesting paper. It was published in November in JACC Cardio-Onc, Allogeneic Mesenchymal cell therapy in Anthracycline-Induced Cardiomyopathy in heart failure patient Seneca trial. I will start by giving you some background information. In the United States, as many of you know, heart failure is projected to increase from 6.5 million to more than 8 million cases by 2030. Despite our breakthrough with medical therapy, which have curbed the mortality in the past few decades, mortality from heart failure remains high. About 5% of patients will have evidence of anthracycline-induced cardiomyopathy, and AIC may be irreversible and carry a poor prognosis. Historical data suggests about 3.5 higher relative risk of death within 5 years. Definitive treatment like transplant remains limited by the donor pool, and we certainly have had many new medical therapies in the past decade. However, stem cell technology in cardiovascular has been investigated as an adjunct to standard medical therapy, and it's very promising. There are several different generations of stem cell lines that have been studied roughly in the past two decades in various cardiac conditions, including acute MI, refractory angina, ischemic cardiomyopathy, and non-ischemic dilated cardiomyopathy. In terms of its mode of action, it was initially hypothesized that the transplanted cells would differentiate into cardiomyocytes and remuscularize the heart. However, there is little evidence to support long-term engraftment of transplant cells, even in the setting of evidence of improved cardiac function. This indicates that the paracrine action is likely responsible for improvement in cardiac function. In this diagram, there are several generations of stem cells, and we will focus on just a few of them for this topic today. So what are potential crucial paracrine action? As you know, adverse cardiac remodeling occurs as a result of imbalanced extracellular matrix turnover and fibrosis, acute chronic inflammation, oxidative stress, abnormal energy metabolism and oxygen consumption, increased apoptosis, endothelial dysfunction, and reduced vasculogenesis. These are the potential targets for our cell-based therapies. Stem cells can attenuate, even reverse the remodeling process by increasing perfusion to the stressed myocardium via neoangiogenesis, stimulating new cardiomyocyte formation, improving existing cardiomyocyte survival by reducing fibrosis through modulation of the extracellular matrix. As a result, one would hope to expect reductions in LV volume, infarct size, and several parameters measuring the LV function. I will just highlight briefly on mesenchymal stromal cells, which was the cell line that was studied in this trial. Mesenchymal stromal cells are fibroblast-like cells, can be isolated from many different tissues, including bone marrow, adipose tissue, and umbilical cord blood. Requires expansion in vitro, cannot be administered on the day of collection. And it's also immunoprivileged, which means it lacks major histocompatibility complex class II molecules and secrete anti-inflammatory factors, making them suitable as allografts. These different cell lines have been studied in various different cardiovascular conditions, and I will just highlight two conditions: ischemic cardiomyopathy and non-ischemic dilated cardiomyopathy. In this TACHAF trial, they've compared autologous BMMNCs and MACs and placebo. These are just different cell lines, and they have demonstrated reduction in scar size using cardiac MR, and improvements in both quality of life and functional capacity, and also 6-minute walk improvement in MSC group. Poseidon trial was another trial that compared autologous and allogeneic MSCs in patients with ischemic cardiomyopathy, and was phase 1 and 2 trial. They've also demonstrated reduction of scar size by about 33% as well as sphericity index, and reduction in LV end systolic volume and LV end diastolic volume, demonstrating reverse remodeling effect. These images were obtained from the most recent review by Dr. Banerjee, and cardiac MRI patients, this is from TACHAF's trial, and it shows cardiac MRI patients before and 12 months after MSC injection. On top, you will see short axis view at the level base, and then delayed tissue enhancement delineated at the septal wall. Also, delayed tissue enhancement corresponds to the scar tissue, and it's brighter than a non-scar tissue, as you can see. And on the bottom, it's a long axis view. So there is a significant change in scar from at baseline and at 12 months after MSC injection. Another area, another cardiovascular condition that had been studied widely is non-ischemic cardiomyopathy. Greater impact on LVEF was seen perhaps compared to the ischemic cardiomyopathy trials. And there were several trials. I'll just point one notable trial, Poseidon dilated cardiomyopathy trial. They've looked at allogeneic versus autologous bone marrow derived mesenchymal stromal cells. It was a small trial, 37 patients with idiopathic non-ischemic dilated cardiomyopathy. They have received either allogeneic or autologous MSCs. At 12 months, LVEF improved from 27 to 35% in the allogeneic group, but there was no significant difference in the autologous group. Based on many of these phase 1 and 2 trials and preclinical data, MSC is thought to have more anti-inflammatory effect, and also allogeneic group perhaps have shown more improvement in 6-minute walk in terms of functional capacity. And perhaps that was the reason why it was chosen for this trial, Seneca trial that I'm about to present. So this is just brief overview of this Seneca trial. It was first trial, a phase 1 trial looking at anthracycline-induced cardiomyopathy, and I'll go into more in detail. And it was randomized, double-blinded, placebo-controlled trial. It was not powered to assess efficacy. It was designed as a hypothesis-generating study. The results will hopefully guide larger studies with regard to selection of appropriate endpoints.
Kristine, sorry to interrupt you there. This is Dan again.
Yeah, no problem.
So could you summarize why they chose allogeneic cells as opposed to autologous?
Sure.
Because I think that's a critical point, especially when, if the basics of, and again, I'm a cardiologist, so I don't know all the details about stem cell transplantation, but I know enough to be dangerous. And, in terms of autologous cells, you wouldn't anticipate that there would be any graft versus host response. Whereas with allogeneic, chances are very likely that you will have at least some graft versus host response. And so I'm just curious if you have any insight as to why they picked that.
Yes, so I might have went through that part a little bit fast. As I mentioned earlier, they are actually, the descriptive word they use is immunoprivileged, meaning they lacked major histocompatibility complex outside, which makes them less susceptible to basically attack by the host, which makes them a very favorable. And this is particularly seen in a mesenchymal stromal cell. So they, as I've mentioned, a couple of the previous trials, they study autologous as well as allogeneic, and they did not see a significant immunologic reactions against allogeneic, and also even showed even better response in terms of some of the parameters they've studied. So even though for non-immunologists, I think they made it easy for us to understand that perhaps allogeneic in this case, unlike organ transplants that we're familiar with, for this particular stem cell lines, that they are not susceptible to immunologic reactions.
And one of the other reasons, hey, this is Jose. One of the other reasons that I read on the paper as to why they chose allogeneic cells versus autologous cells was because of the concern of reactivating the malignancy if they were to use autologous cells. I think there was one sentence or two on that on the paper as well.
Yeah, very good. Yeah. Okay. So just going back, so this is the diagram that shows how the patient was screened, enrolled, and treated. So they've selected patients, male and female cancer survivors, age 18 to 79 years, with the diagnosis of AIC. And these were some of the inclusion criteria. They received initial diagnosis of A1C at least 6 months prior to the consent, and LVEF less than or equal to 45%, and receiving stable, optimally tolerated therapy with beta blockers, ACE, ARB, and or aldosterone blocker unless contraindicated. No evidence of ischemic heart disease. And they needed to be cancer-free for at least 2 years with a low likelihood of recurrence. And they, once they've been selected from the pool, the baseline evaluation took place within 45 days of obtaining the informed consent. And the evaluation included cardiac MR, 6-minute walk test, Minnesota Living Heart Failure Questionnaire, and comprehensive lab panels, including NT-proBNP. And then the allocation started and was randomized. But before they were able to start, they had to first demonstrate that this is safe and feasible. So there was open label lead-in with 6 patients, and they received intervention. And once it was approved by FDR, they were able to go ahead and randomize to LO-MSCs or placebo. So about 6 people were in open label lead-in, and 14 in LO-MSCs, and 17 in placebo group. And all everyone underwent baseline testing prior to randomization, and they had 6 months follow-up and 12 months follow-up. And at 6 and 12 months follow-up, they repeated a cardiac MR, 6-minute walk test, once again answered the Minnesota Heart Failure Questionnaire, and NT-proBNP was obtained. So LOMSCs, just briefly, they were manufactured and released by the Center for Cell and Gene Therapy at the Baylor College of Medicine. And the cell bank was generated from about 25 to 50 milliliter of bone marrow from a single healthy donor, in this case, female, age 27. And they were expanded to a final dose of one time, 10 to the 8th, and they were administered via NOGA catheter, and 20 transendocardial injections, about 0.4 milliliters each were administered. And this is the diagrams showing some of the different ways of administering. In our case here, this was transendocardial, but there were some other techniques, including intravenous, intracoronary, and intramyocardial have been done in the past. TESC stands for percutaneous transendocardial stem cell injection, and using NOGA myostarter catheter. And this really allows for electromechanical mapping to accurately delineate the area of infarct and guide injection into the border zone. And this is one of the mapping that they have shown us. So this is LV electromechanical 12-segment polar map representing unipolar voltage. On the right, there's a scale depicting the voltage values represented. So in black, the black dots are 12 injection sites. These are the areas of intermediate voltage, 4 to 8 millivolts. And red areas are lower voltage value representing fibrosis. So they've targeted partially fibrosed areas. So, and that can be determined by intermediate voltage. So more peri-infarct areas is another way to put it. And all of these people.
To that point, so this technique was in people with, when it was utilized in people with ischemic heart disease. So these patients, they were all felt to have non-ischemic cardiomyopathy from anthracycline. So is this same technique what they used? Like they found areas that were more fibrotic than others?
Yes, this was actually one of the examples they've demonstrated. I wonder about the same thing as well, because I would also expect that fibrosis to be a little more diffuse compared to the ischemic. But I think the similar approach was still demonstrated in this trial, which is kind of interesting to me as well.
Yeah, I mean, I think at least conceptually, so I don't know if clinically you could actually do this, but at least conceptually, the places where a stem cell might be helpful would be the admixture between normal versus scarred or ischemic, ischemic tissue. So that area where it's vulnerable. So you in theory, if you injected stem cells in that area, then, perhaps they would take hold because those areas are hungry for, either improved blood flow or better mechanical function, whatever theory you're playing forward. But, in these patients, you wouldn't necessarily expect to see patchy areas. I mean, maybe, I don't know. I mean, I haven't ever done one of these heat maps for injecting stem cells, so I really don't know what to expect in terms of, these patients, what you would expect to see.
Yeah, it's a very good point. Because another thing that I also wonder about this trial was they've done different measurements in cardiac MR, but it didn't really demonstrate different scar patterns or improvement in scars, which will help us to kind of see if this admixture of fibrotic tissues and living tissues or how it was distributed in this particular population. That would have been very good thing to observe. But they did not go into details about that.
Okay, thank you.
Yeah. Okay. So they followed up these patients for 1 year, and so 0 is day of injection, and they obviously kept the patient at the following day and observed them, and then assessed them in a week, a month, and 180 days and 365 days. At each visit, a physical exam, ECG labs, and like I've mentioned before, 6-minute walk test and Minnesota heart failure questionnaire, and also a CMR they underwent CMR as well. Interestingly, immunologic monitoring also happened using a panel reactive antibody collection, and that were analyzed. Like we mentioned before, they are interested in to see if there are immunologic reactions to this allograft. So this was a phase 1 trial, and their focus is to see the safety of this this technique in this population. Their main focus was adverse events and MACE events and others. They still looked at significant clinical outcomes. Obviously, it's not powered. And some of the efficacy endpoints they've looked at using CMR as cardiac function, using LVEF and global and regional strain, and cardiac structures, including LV index, systolic volume index, and systolic volume index and sphericity index. They've also looked at the changes in the area of injury. If functional capacity was measured using the 6-minute walk test, and changing quality of life, which is often used in heart failure trials, using one of the questionnaires, Minnesota heart failure questionnaire, and clinical outcomes like MACE and biomarker NT-proBNP were collected. So just to briefly go over the patient characteristics here, the mean age was 56.6 plus or minus 11.8. There were 68% women and 32% non-white and 14% were Hispanic. Pretty diverse population, and more women than historical trials in the past. And average LVEF at baseline was 33 plus or minus 5.3%. And about 84% of the patients were NYHA class 2. And average NT-proBNP was 1400. And all subjects were maximally tolerated, were in maximally tolerated medical therapy for heart failure at the time of consent. And 58% of the randomized patients actually also had a cardiac device, either ICD or pacemaker. In terms of oncologic disease, 48% of these patients had history of breast cancer, 19% non-Hodgkin's lymphoma, 10% leukemia, Hodgkin's, and 3% Hodgkin's and 3% sarcoma. And about 16% of the patient had more than one cancer in their lifetime. In all cases, first instance of cancer involved treatment with anthracycline. The average interval since cancer diagnosis was 17.7 plus or minus 8.9 years. Since last cancer treatment was about 15 years plus or minus 8.4. 90% of the patient had doxorubicin and 10% of the patient had apirubicin or daunorubicin. Fortunately, they did not collect, were able to collect the lifetime exposure to these agents. The average time since AIC diagnosis was 7.5 plus or minus 5.5 years. So this is just wanted to briefly go over what they've shown us. So this is events grade 2 or higher in severity on MADRS system organ classification. They collected all the adverse events reported by the patients and in various organ system. More interestingly here, this is the adverse events that are considered more serious, and they were about 4, there are 8 subjects total who experienced serious adverse events that were cardiac in nature, and 4 in each allogeneic MSC group and 4 in the placebo group. Non-cardiac events did not really differ significantly between the 2 groups, and no acute or chronic immune reactions to the study product was observed, which is one of the key important information here, given that this was an allogeneic MSC cells. This was a distribution timeline of adjudicated clinical safety outcomes. 10 clinical endpoints were adjudicated in 6 subjects, including 1 death due to progressive heart failure, 7 hospitalizations for worsening heart failure, and 1 non-hospitalized heart failure exacerbation, and 1 hypersensitivity reaction to CMR contrast agent. There was 1 heart transplant patient, but however, that was not a pre-specified clinical endpoint. So some of the secondary efficacy endpoints, obviously they're not powered, but just for observation was demonstrated here. So this is not including the 6 lead-in patients from the open label initially. And 10 of 13 efficacy measures favored LO-MSCs. And this, and like I've mentioned before, this is a phase 1 trial and not power. So we need to take this information with a grain of salt. But something that these are the potential endpoints and clinical outcomes that we can look at in future bigger phase 3 trials. But there was one area that was interesting that was statistically significant. Really, it was the Minnesota Heart Failure Questionnaire score. So in allogeneic MSC group, about there was a decrease in the score from 46.6 to 21, compared to the placebo group of change from 53 to 40. The difference in the changes between the 2 treatment group was about negative, about 12.8. So this was one area that was interesting observation. I've included some of their supplemented figures that were kind of interesting. So this is a graphical depiction of change over time for each of the 13 efficacy measures, but I've selected the ones that they show some significant changes. So on the left, you see that LV sphericity index showed a significant interaction over time between treatment groups, with a decrease of 0.042 per 6 months in the placebo group. And in this case, it actually favored the control group. And there was also significant difference in regional longitudinal strain favoring the, in this case, LO-MSC group compared to the placebo group. The Minnesota Heart Failure Questionnaire score also decreased by 14.8 per 6 months in the LO-MSC versus placebo group. But this was not statistically significant. So just to kind of go over some of the limitations of this study, that in general, anthracycline-induced cardiomyopathy population is pretty heterogeneous in terms of the type of cancer, as you saw in this trial, and number of cancers in their lifetime, chemotherapeutic regimen that they've been exposed to, and also additionally, some of them have been exposed to radiation as well. Also, the limitation, another limitation was the interval elapsed since the end of anthracycline treatment was quite long, averaging about 13 to 17 years. And the long-standing myocardial changes that can, in the setting of this long-standing myocardial change, there's a question whether after the changes have been so prolonged, if they would benefit from the cell therapy. Also, they had a lot of difficulty obtaining older medical records, including the amount of anthracycline exposure. So these are some of the challenges they had. And obviously this was a phase 1 trial, so we did not see a significant clinical outcomes that we would normally want to see in a bigger trial. But in summary, so what this important trial really demonstrated that was a transendocardial injection of allo-MSCs is feasible in patients with AIC. And there was no difference in terms of safety signals between the two groups. And most importantly, no immune reaction to the allogeneic cell product is shown in repeated PRA analysis they've done throughout the trial period, confirming that allo-MSCs can safely administer without triggering activation of the immune system. And they've also have been successful in testing patients with cardiac MR safely and effectively in patients with devices. So that was their other interesting point. Just to summarize what we know so far, there have been numerous preclinical phase 1 and 2 trials, and in fact a few phase 3 trials that have been published and are ongoing for the past 2 decades. And no trial has yet to have been powered sufficiently to demonstrate mortality benefit. And variety of cell lines were studying various cardiac conditions, demonstrating safety and feasibility of this trial. And really the next step here is to taking it to the next level and completing the ongoing phase 3 trials that are going on, and testing even more specific stem cell lines targeting myocardium, more specific to the injured myocardium. So these are some of the hopes for stem cell technology. This was a small trial, but it was a very important and interesting trial, and I really learned a lot from it.
So let me ask you, if you had gotten anthracycline 8 years ago and you had an EF of 35% or somewhere, wherever the criteria were for this study, would you agree to a trial with a mesenchymal stem cell infusion? Would you agree to it personally? Just based on what you've read or what you've seen?
That's a tough question, Dan.
Well, no, it's not. Because do you think that there's compelling evidence based on your review that this could be helpful?
So I've looked through a couple of different review articles, and there have been a lot more than I realized on this subject. And there were a lot of trials actually, but most of them are quite small. Even the largest trials I think I've seen was 300, and what did not really show clinical outcomes that were significant. So as of now, I might not, but I still do think that this is the future. I think what was interesting was I've mentioned in the earlier slide that they are different generations of stem cells, and more they're getting better at selecting out very specific stem cells. And I think as the technology gets better to harvest the stem cells that are more targeted, just like immunotherapy in some sense, that we might be able to find stem cell that might be a perfect combination of what we need. And there might be different stem cell lines that might work in different conditions. Right now, I think we have a very heterogeneous type of cardiomyopathy, and we are, in my opinion, in some ways random at picking which cell lines to use. But I think as we get better at finding the right stem cell line and picking out the right population, I think we'll be able to do a bigger trial that shows efficacy. But I think at current state, we still need some more work to do.
Well, I would say that, you know, I've struggled with this whole concept for quite some time because, you know, and again, I'm not an expert on stem cell transplant, but you know, I've seen a lot of patients who have gotten them. So I have at least that sort of experience. But if you were a blood cell and you were in somebody's bone marrow, and then you were taken out of that bone marrow and injected into another person, where do you think you would go? If you were a bone marrow cell, where would you go? You're not going to go to the heart. You're going to go to the bone marrow because that's where you came from. And so we have sort of observed in stem cell transplantation for cancer that the group that benefits are people that have hematologic stem cell abnormalities. And solid tumors really don't respond. There was several trials years ago looking at breast cancer and some other solid tumors to see if they were benefited by stem cells. But, you know, so to imagine that a stem cell is going to go to the heart, set up shop, make a house, and start working is, I think it's too big of a stretch. And I don't really think that there's been compelling evidence shown by all the stem cell trials by injecting them or putting the pellets in or any of that to where those stem cells actually transform into a myocardial cell and then actively work like a myocardial cell. So I'm not sure I've seen any of that. I don't know what you think about that sort of general idea.
Yeah, so I mentioned in an earlier slide that still mechanism is unclear how it works here, but the stem cells actually don't transform into myocardial cells per se and remuscularize like a lot of us would think of in this type of technology. But in fact, they produce, they have more of I guess, enzymatic effect by producing certain enzymes that would help have a paracrine effect. But I think that's one thing. And the secondly, they are developing next generation of stem cells that are a lot more specific and more cardiophilic, for lack of a better word. And so I think it's still in a very earlier stage. And once again, I'm not an expert in this area either, but I think there is hope that perhaps we will find a stem cell line that would work better for myocytes.
Sure. No, I mean, I was asking you a question that's like impossible to answer. I understand that.
Yeah. Oh no, that's fine. I mean, it's good to think of, you know, what is really happening in this area. That's so interesting and fascinating. But just like in other areas, and especially in oncology, that this had been studied, I think it's definitely worth trying in cardiology.
And I saw several of your Sloan Kettering colleagues on the line, but nobody has said anything. So
well, I've been muted.
No, you haven't.
Okay, now unmuted. Yeah, hi, Dan.
Hi,
It's Richard Steingart from Memorial. Hi, Kristine. Great job.
Oh, hi.
Good
Thanks
to
for
see you
joining
again.
us.
Yeah, sure. So you're coming from a background of advanced heart failure, and so you are used to living in an environment of very aggressive interventions. So what was your experience with anthracycline cardiomyopathy? Did you have personal exposure to patients with anthracycline cardiomyopathy in the advanced heart failure world? Devices, transplants, etc.
So my center was relatively new center. I saw a patient who had anthracycline-induced cardiomyopathy exposure many years ago. She came in with actually heart failure symptoms for the first time, but her LV wasn't that dilated. That was her first time heart failure, so she was not yet a candidate. Hopefully not in the future for advanced therapy. So I have not personally seen patients who underwent LVAD or heart transplant, but I've heard from my colleagues and other institutions where they have actually transplanted a heart, new heart in a patients with anthracycline-induced cardiomyopathy. So even our experience here in Memorial, I have not seen patients. I think the most common ones that we see with anthracycline-induced cardiomyopathies are usually mild LV systolic dysfunction, and oftentimes with really minimal symptoms. So I don't see why, based on that information, I don't see why not we would treat these patients in terms of advanced therapy any differently than other non-ischemic cardiomyopathy, as long as there's no recurrence of their primary cancer or new cancer.
So I think one of the limitations that you mentioned earlier about, you know, the time from previous anthracycline to whenever they got this procedure, you know, that's pretty significant, because I think in the stem cell for heart failure world, all of the previous studies, and maybe 5 or 10 years ago, there was a big flurry of studies in this regard. Most of them were aimed at, you know, people that had a recent infarct. And the idea being that you got to those areas that may have been at risk, but were not dead. You got to them relatively early, and that would help, you know, enhance, you know, fixing of the stem cells to actually exist and stay there. And so in this particular trial, since the injury was many, many years ago, you know, there's no injury sign that's happening in these patients. So that may be a very important limitation that you brought up.
Yes, and that was the authors definitely admitted to that they couldn't even find how much anthracycline they were exposed to. We usually try to figure out based on the the exposure. We try to figure out the exposure based on lifetime dosing, and they weren't able to do that. But one thing I would like to add, though, is sometimes these more advanced heart failure in AIC patients, at least from my short experience, usually they present many years later. So when they're actually going through anthracycline or even a few years after, sometimes their dysfunction might be very subtle, but somehow over time, maybe a lot of times the surveillance is not ongoing, and they present several years later. So I don't know if at what point they actually developed the end-stage heart failure. But well, I think that's another interesting part of this AIC patients. Yeah.
Yeah, I mean, I think Jose has current experience with a patient that triple-negative breast cancer that is, you know, severe heart failure at this moment, just got chemo.
I was just going to mention that in my experience, I mean, I'm an early career heart failure cardiologist, so I've noticed that, you know, children who got exposed to anthracyclines, they tend to have a more indolent course. And yes, I've had patients that have progressed to needing a heart transplant, but compared to adults and young adults getting anthracycline therapy, either for lymphomas or in the case of that patient, breast cancer, I've noticed that, at least based on my experience, those patients have been requiring more urgent types of interventions, such as LVAD or you know, the natural history of their presentation and their condition has been a little different. I think that, you know, for me, that's been interesting and something that I keep track of in my mind. Like, is there a huge, you know, a difference in terms when the patient was exposed to anthracycline and the presentation and the severity of their heart failure, the acuity?
So you currently have a patient who just had an exposure to anthracycline and had
so it's actually an interesting case. The patient was actually pregnant when diagnosed with breast cancer, triple negative breast cancer, got, you know, five cycles of AC therapy, so over, you know, 300 milligrams per meter square of doxorubicin, and about, you know, 5 months later presented with severe, you know, severe heart failure, and now, you know, it's requiring, you know, multiple hospitalizations, inotropes, and ongoing discussions as to, you know, what the next step should be, because the patient is a relatively young, you know, person.
I mean, yeah, go ahead.
Could I ask a question? This is Jennifer. Kristine, great job. So do we know from the prior studies that have been conducted, the duration of that positive reverse remodeling effect? I mean, that is something that I question, you know, even for the studies that have shown a benefit. How long do these effects last for? I know you've stated there's been no effect on overall mortality.
Yeah, so I've actually looked back since you've asked that question earlier. There aren't that many trials that really went beyond 1 year. So I don't think there's really long-term data. That's another limitation in currently, that there is no long-term data.
I have to say, I know very little about this field, but I can say that if this has been going on for 2 decades and they have not had long-term data, this is like the echo contrast perfusion story. Yeah. It's you know, you kind of question where this is really gonna, you know, the future of this field. That's my 2 cents.
Yeah, I mean, I think that the most compelling study that has been published to date was in ischemic heart disease, and they really only followed the patients for 6 months to a year. So, the most compelling finding was pretty soft. I think it was like a reduction in ischemic burden, I think was the main finding. So I don't really feel like there's a lot of evidence that this theory holds water. I know they talk about the paracrine effect, but you can't measure that. It's not like you can take a blood sample and say, oh yeah, this stem cell is making nitric oxide or whatever it's doing to try to enhance, paracrine effect in the heart. There's no blood test that you can do. There's no non-invasive test. So it's really just your belief whether it's actually happening.
Yeah, and I was also very surprised to find that there have been so many trials, and yet as a cardiology trainee that I have not heard so many of them. And perhaps the reason is there hasn't been really robust results, despite of 2 decades of studies.
Yeah, no, I think this was, I'm really glad you looked at this study so carefully and did this presentation. I think it's great to look at these things. But yeah, this trial I can't say that it convinced me that the concept was valid. You may have been able to demonstrate that it was basically safe to do this procedure, and that's the purpose of a phase 1 trial. So if that was the primary purpose, then I think that was achieved. But whether you got any sort of efficacy indicator that was showing a real benefit, I'm not sure that I see that.
Yeah, I agree.
All right, do we have any other questions? There were lots of people listening. Nobody, I don't know if they had any other thoughts. Joe Carver, do you have any thoughts there? You've been in this game for a while. Nope. I guess everybody's quiet. All right, well, thank you so much. This was really great. Steve, do you know what our next week's presentation is?
Yes, Dr. Miriam Lusberg from Ohio State. She directs the survivorship clinic there. So another oncologist will be presenting on optimizing cancer survivorship and cardiovascular outcomes, gaps and opportunities.
Great, thank you so much. Sounds awesome. All right, well, thank you so much, Kristine. Nice to meet you. I wish it was in person, but.
Yeah, nice to meet you. Hopefully we can all meet in person. Thank you for the opportunity, and thank you all for joining.
Great. Thanks a lot.
Thank you.
Thank you. Bye-bye.
Thank you all. Bye-bye.
Bye-bye.
Thank you.